Hello. My research proposal is on medical desert's effect on varying communities in Kentucky. When exploring the topic medical deserts, we first need to go over some of its history. In recent years, the medical field has made considerable advancements in research development, accessibility, technology, and inclusivity. Despite these milestones, certain populations still seem to experience medical insecurities, which can leave large areas and populations without proper access or no access to healthcare. These areas are classified as medical deserts. The term medical desert was modeled after the original concept of a food desert. The term food desert was created in 1995 and used by the United Kingdom Nutrition Task Force to identify and study food and nutrition insecurities in Scotland. The terminology of a food desert describes an area where people have limited access to affordable, healthy foods outside of a 30-minute or 20-block radius. In response to having a controlled availability to affordable, healthy foods, many would turn to cheaper, less nutritious foods, eventually leading to a population of very unhealthy people that could directly correlate to the foods that they ate. Some common diagnoses were obesity, high blood pressure, diabetes, anemia, COPD, and even infertility. This concept was then applied and modified to establish a new term, a medical desert. Medical deserts can be described as a certain area in which healthcare services are extremely limited or altogether unavailable, such as medical, behavioral, dental, and or pharmaceutical services. The term medical desert is a newly adapted concept. As we continue to identify and locate areas of medical deserts, different categories of the term seem to arise. Medical deserts are created due to several factors: increasing hospital closures, decreasing hospital funds, location, trauma center status, population, preventative care facilities, provider shortages, staffing shortages, and more recently, the COVID-19 pandemic. Understanding and identifying certain contributing factors to medical deserts will help limit their growth and ultimately decrease preventable deaths. Furthermore, by understanding what contributing factors have the greatest impact to certain medical deserts, clear definitions and classifications can be established. The awareness of the severity of the generational effects medical deserts influence on a community may also encourage communities and government funding to value patient education and healthcare literacy. Initially, when I started researching medical deserts, I found that there weren't a lot of academic scholarly articles to support or describe the topic. As of now, there is only one governmentally approved definition of medical deserts that I described before. This is a very vague and broad definition that doesn't accurately describe the effects that medical deserts have on certain communities. I believe that there's not a lot of research on medical deserts because it is such a difficult, evolving topic, and it can affect a variety of communities in many different ways. The most groundbreaking research that I found during my research was conducted by Evanstein Garcia, a PhD student at the CUNY School of Public Health in 2018. He studied the effects of urban medical deserts on two different urban communities. And even though these two communities were classified as urban medical deserts, they were experiencing the medical desert effects in many different ways. This helps us believe that more research should be going into medical deserts to find out how other communities are also struggling with medical insecurities. Location and population can be good identifiers to the accessibility of healthcare. The United States Census Bureau created these categories of rurality to help establish a need in certain communities that would then help them distribute medical supplies, regulate procedures, promote employment, and disperse funds to certain resources. These reports show which counties deserve the most government assistance to fund a variety of resources. Urban regions are described as areas with a population density of over 1,000 inhabitants per square mile. Rural regions are described as areas with a population density of less than 1,000 inhabitants per square mile. And frontier regions are described as areas with 10 or fewer inhabitants per square mile. According to a 1994 United States Census Bureau population report, 442 counties were identified as frontier and 1,831 counties were identified as rural. Medical deserts are described as areas with limited access or no access to certain medical services. Location and population also contribute to this. As you can see, most of the western United States is identified as frontier counties, and most of the mid, southern, northern United States is identified as rural counties. The white areas show counties that were identified as urban. As you can see, most of the population is located in rural and frontier counties. Even though we have clear definition of counties based off of population, no clear definition of urban, rural, or frontier medical deserts have been established, and that's what I would like to do in my research project. Referring back to Garcia's research on medical deserts in 2018, I would like to use his model that studied urban medical deserts to study a variety of medical deserts in Kentucky. I hope to identify urban, rural, and frontier medical deserts in Kentucky and also study the unique contributing factors of each medical deserts and how they affect the communities. Currently, there is only one governmentally accepted definition for medical deserts, which is a certain area in which healthcare services are extremely limited or altogether unavailable. Using geospatial engineering components in Google Maps, I created this map, which compiles information such as hospital status, trauma center status, and location and its population to create my own definitions of frontier, rural, and urban medical deserts. Frontier medical deserts are classified as taking 90 minutes or more to reach a trauma 2 care center. Rural medical deserts are classified as 60 minutes or more to get to a trauma 2 medical center. And urban counties are classified as 30 minutes or less getting to a trauma 2 medical center. Even though this map is compiled of hospital status, trauma center status, population, and location, other factors besides those affect medical deserts. Based on the information provided, I identified 6 regions of Kentucky to be classified as urban medical deserts. Some of them make sense as they're well populated areas, such as northern Kentucky, Lexington, and Louisville. But some areas you might question these are really rural areas, so why are they classified as urban medical deserts? Bardstown, Maysville, and Pikesville are all classified as urban medical deserts is because they are relatively close to trauma 2 or above hospitals located across the border in Tennessee, Indiana, West Virginia, and Virginia. Even though they are Kentuckians, they rely on medical services provided by other states. After analyzing the information from Google and the American Physician Association, I was able to identify hospitals, hospital clusters, and trauma 2 level centers or above. As you can see, some medical deserts are relatively close to trauma 2 level centers or above. There are also trauma 2 level centers and above that are not categorized as urban medical deserts, and that's due to utilization rates and location. Frontier medical deserts are classified as counties that take greater than 90 minutes to reach a Trauma 2 level facility or greater. As you can see, this affects most of eastern, western, and southern Kentucky. Based on the information provided by the hospital overlay, you can see that these frontier medical deserts do have access to hospitals, just not trauma 2 level centers or above. You can also see that some trauma level 2 centers or above are close to the outlines of these counties, but just because it's close doesn't mean the whole county should be classified as an urban or even rural medical desert. After analyzing the different categories of medical deserts, I would like to research how can we identify and assess the impact of contributing factors of medical deserts to better define each classification. My research study would be classified as an observational analysis. The creation of medical deserts are contributed to a variety of factors, such as socioeconomical factors and hospital statistics. Each of these factors disproportionately affects each category at different rates. This observational analysis study will span over 3 years, analyzing how these factors affect hospitalization rates, emergency department utilization rates, and preventable death rates. The study will analyze certain socioeconomical factors in hospital statistics, such as patient to staffing ratios, family size, annual income, insurance status, physical distance, public transportation arrival time, driving arrival time, and overall public health conditions and trends, and how these factors affect hospital utilization rates, emergency department utilization rates, and preventable death rates. All of these factors will also vary by location, such as urban medical desert, rural medical desert, and frontier medical desert. The predicted outcomes of this observational analysis would be that when comparing different medical desert regions, such as urban, rural, and frontier, the frontier population is expected to display greater healthcare disparities and medical insecurities, shown by higher hospitalization rates, higher emergency department utilization rates, and preventable death rates due to identifiable specific contributing factors. The null hypothesis would prove that when comparing different medical desert regions, such as urban, rural, and frontier, no particular region will display greater healthcare disparities and medical insecurities. The independent variable is location, depending on medical desert status and hospital certification status. The outcome variables will be hospitalization rates, emergency department utilization rates, preventable death rates, and identifiable contributing factors. The data collected for this observational analysis will be collected through hospital reporting agencies and by a patient survey consisting of a sample questionnaire. We will ask patient and patient families to fill out an interactive survey consisting of sample questions that consist of asking about socioeconomical statuses. This includes insurance status, family size, annual income, physical distance, transportation information, and other questions. This survey will be available at multiple hospitals in different regions over the span of 3 years. The results of this questionnaire are expected to be skewed due to COVID-19 pandemic, as hospitalizations, emergency department utilizations, and preventable deaths may be spiked due to COVID-19. The overall goal of this observational analysis is to clearly identify the problem to create a holistic population-based approach to help limit the growth of medical deserts. To do this, we'll start at the beginning by first identifying medical desert areas. We will then identify certain contributing factors and then identify what contributing factors affect what specific area the most. We will then analyze how these specific factors impact patient care in that area. Then we will be able to create a holistic population-based approach for that specific region. This allows each region to properly disperse funds and other aspects to be able to provide for the community. Unfortunately, there seems to be no clear solution to the growth of medical deserts. We have been able to identify some temporary solutions. Telemedicine helps connect patients with accredited providers no matter distance or affordability. The only problem to telemedicine is that some people might not have the access to quality internet or be able to understand how to use it. The Affordable Care Act ensures that everyone has insurance so that they will be able to go to the doctor to at least seek the care that they need and cannot be turned away from an emergency room. Some insurance reimbursement programs help incentivize your health, such as paying for gym memberships or giving you kickbacks or discounts at certain local healthy options. There is a government-funded healthcare provided student loan payoff programs where if you work in an underserved community, they will help you pay off your student loans. Recently, NKU's CINSAM program, the Center for Integrative Natural Science and Mathematics, has partnered with the Cincinnati Children's Museum to help NKU students display their research to a variety of audiences. This includes creating an interactive exhibit for children to help display your research and encourage children to go into STEM. My interactive display for the Sensam program turned out to be more of a model. It consists of 3 layers, one wooden and two acrylic. The first wooden layer shows all of the Kentucky counties. The next acrylic layer shows medical desert classifications that will then be baked with glass paint so that it will look like a stained glass and you will be able to tell color differences based on the medical desert classifications. This takes 4 days to cure and it wasn't ready by the time I was going to present this project. The final layer has circles and dots, which classify hospitals and level 2 trauma care centers. This way, children can see all where hospitals are, where medical deserts are, and their counties. If you made it to the end, I would love to get some more feedback about how to make this more of an interactive exhibit instead of a model. Here are the resources that helped me come up with my project proposal and helped me make my model. I would also like to thank the NKU Stego Lab for helping me create the Skimformatics to print my model and using the Glowforge. I would also like to thank the NKU's art department for helping me find and supply the correct stained glass paint.